She is 44 years old woman, and she came to the office because she doesn't like her smile, because it's you see, it's asymmetrical, because she had an orthodontic treatment when she was a child, around 11 or 12 years old, when the canines erupted. In the first place, she got an orthodontic treatment plan without extraction, and when the left canine, left upper canine started to erupt, the doctor decided to extract one of the premolar. So that's why she's asymmetrical. So this is her chief complaint. And the other complaint is that she's her profile. So she has a negative step at the lips. Those. So here you can see that one of the premolar is missing. And I left the nose on the occlusal view, so we can see the asymmetrical arch. On the right side, she has a class 1. On the other side, the molars class 2, and
the canine class 3.
And the canine, yeah. So the natures of the problem
is the orthodontist.
Okay. And I go. This is the OPT. So there we see the symmetrical upper arch. And so I move on.
Mm-hmm.
This is her Ceph. I think she has a straight profile, so skeletally she has no problem. Okay, I move on to the occlusogram. Should I open the occlusogram?
As you like. I mean, if we have to modify it, yes. But for now, I would say it's okay. We can also see it like that.
Okay. In the first place, I would like to. So I decided that need a space opening on the left side for an implant. So that's why I put here the measurement chart. And I try to set the occlusogram that way.
I think the general idea is perfect, Gabby.
And I want to protrude the upper incisors because of the lips.
The only thing we have to check in this case is the symmetry axis, because I'm not totally convinced. The anterior movements is pretty clear, but I'm not totally convinced about your symmetry axis and the transversal movement that you are planning. Okay.
So I opened the occlusogram.
We open the occlusogram. Okay.
Okay. Just 1 minute.
Okay.
Go back to the symmetry axis.
Yeah.
Yeah.
Okay. May I take control?
Yes, sure.
You have a request? Thank you. So again, we'll start placing the control here in the middle of the crowns, okay? I always do this, and after that, we work on that. So if the molars are perfectly symmetrical, you see, I'm just centering this. This means they are perfectly symmetrical. Is your midline position here consistent with this symmetry line? What does it mean? Here, for example, I see the upper midline, which is deviated from the symmetry axis. We can measure it. No, I don't have the ruler, but maybe this is 3 millimeters, okay? And is in the picture, is this 3 millimeters, is it the midline 3 millimeters deviated to the left, the dental midline towards the facial midline? Question. Can't remember, but maybe it's
yeah, 3 millimeter.
okay.
I measure it.
Okay, so this means that you can consider the upper molar as symmetrical, which is usually a good thing, and move all the other teeth. Now we give also a look to the lower, and I see that also the lower are symmetrical. So in this image, they seem to need expansion, but this is not a need for expansion. But you should see, okay, you see that here is on the buccal distal cusp, and also here. So it's these 2 points are in a symmetrical position, more or less. Maybe there's a tiny difference, but not very much. So if we choose this, which is not what you had chosen before, we have a quite simpler and more linear treatment plan, and which is consistent with the facial midline. So personally, I would consider this symmetry axis. Okay, you understand why I'm saying this?
Yes, so that means that the upper molars are okay.
No,
right?
no, it means that they are symmetrical. Maybe you want to expand them, both of them, but the expansion will be symmetrical. Maybe you want to contract, but symmetrically. Maybe you want to
Okay.
distalize or mesialize, but it will be the symmetrical. Okay? So the meaning of the symmetry axis is not they are okay. It means they are symmetrical. So either they don't move, and so both of them, they're not moving, or if they move symmetrically. So symmetrical expansion, symmetrical contraction, they have to go to the distal the same amount, to go to the mesial the same amount, and so on. The only thing that could be happening asymmetrically is a rotation, but besides that, it's the same. Okay, so I would keep this if you don't mind. Of course, you are the doctor, so you will treat the patient, and it's up to you. But if it was me, I would consider. And another thing you could look. Usually, I mean, this is not a real must, but you see the raphe? Yes. It's right here. So it's also corresponding. So there is no reason to choose another symmetry axis. Okay. Okay. Now that we have clarified this issue, we can go on, and you go back to the other part of the occlusogram. Yeah, that stays the same. You go here.
Where?
I've done it for you. Sorry.
Okay.
Okay. So now you see now the molars are more or less, you don't have to make asymmetrical expansions. So but you have a tiny expansion on both sides. And what you have, it's no distalization on both sides. And what you have, it's a mesial movement of this area, the rotation of this group, an expansion of this area. So the premolars have to be expanded, unless you want to contract this area here. Okay, in this way you are not, I don't know what's happening. Okay, I don't like it, but just to tell you. Okay, if I put it like this, there is basically no expansion in the premolar area. Okay, maybe you can, I would expand a little bit, but maybe something in the middle, what you had decided. Okay. It's very hard. I mean, you know, when I'm doing it remotely, I'm always doing too much, too less, and I have no control. Okay, let's leave it like that. But you can adjust it as you like anyway later on. So, but now the things are that in this arch, you have a lot of good references. Now, the molars, the first molars are actually not moving. And premolars on the right side have to have a minimal expansion. And also the second premolar on the left side needs expansion and rotation. I will go on drawing this. So this is Anchorage. This is Anchorage. You might consider a little bit of rotation here, but it's not significant, and a little bit of expansion here. And this is like this. You can do this maybe in the first month or two, or you can do it at the same time when you start working with the anterior. Now, if you look at the anterior, I would say that you should move the anterior always as a group. And the point is whether to move 5 or 6 teeth. That's usually the problem. I would say that for my experience, the best thing would be to move these 5 teeth together. And once you had expanded this area, you know, this teeth would be probably here. At any stage, at the beginning or during the movement of the anterior, I would use a rectangular loop to expand, rotate, maybe with, you are going to create some space here because you are expanding this area. So if you have 1 millimeter space here, you will close it with an elastic chain. This is also important because we are moving the teeth in this direction. Now, the main thing that you have to do here, it's the movement of the anterior. Now, the movement of the anterior, you have to analyze the movement with maybe with DMA if you want.
Yeah, I put it in the DMA, but I didn't know that I can move the whole group, the 5.
Okay. So that's interesting anyway. We will review this again, and no, that's no problem. But I wanted to say you something. When you do a DMA, it's important that you do, in a case like this, the evaluation both on the lateral cephalometric and on the occlusal. Can we go, I mean, I actually have control, so I can go here. Sorry. You are planning a translation in this direction, okay? Which is perfect. But if you are really want to do this, you cannot apply a force at bracket level. Theoretically, you should apply it maybe at this level. But if you cannot do it, at least bring it here with some extension. So this is very important because we will need to decide the vertical level of the force. I don't think that in this case, with this amount of advancement, it's a critical issue. But considering that these incisors are not vertical at all, I think there is the indication of raising the level of the force, maybe 5-6 millimeters or something like that. And this is an important information. Okay, now I would like to see, Gabby, your DMA. If you don't mind.
But it's wrong because I moved the incisors.
There is nothing wrong. It's a different treatment. It's not wrong. Okay.
Because I made a group with the 4 incisors. And I left the canal.
No, you know what?
I didn't know that we need one step or 2 steps.
Okay, we redo it from what you had. But also here, the occlusogram is not correct. You see, I mean, you have this movement of the posterior teeth, which would be very difficult. You know, asymmetrical expansion and asymmetrical. This goes to the distal, this goes to the mesial. Why that? I mean, you're making a very complex thing. So, okay, we do this again, and you go back to the occlusogram, and from there you start a new DMA.
Okay.
I leave this to you again? I would do more rotation with the other.
But if I do a more rotation here, the incisor go to bottom.
But now it has to go more forward.
Oh, okay. Here? Is it okay now?
Probably yes. Maybe a little bit more. Consider that you are tracing the the outer part of the crown, but actually the occlusogram is passing through the incisor ledge. So maybe you are close to the right thing, or you can go a little bit more forward, but I don't think this is so important. Maybe you can go forward another 0.5 millimeter.
Okay.
Okay, stop here. Now, if you have seen this, now you can see the line of action of the force. Single force. And you see that the line of action of the force passes in the middle of the right central. What does it mean? You should attach it to the bracket of the right central or to an extension coming from it up.
Okay.
So how can we do? I mean, of course, if you attach it to the bracket is simpler, but as I said, we wouldn't like to have too much. We say that the force should be applied here or here. Okay, so first of all, you need a very rigid wire. And if you want to do it with one wire, it's quite complicated. So you should do something like this and use this extension to attach the cantilever. Unfortunately, I mean, I don't think you can do it more than 5 or 6 millimeters, because if you do it, probably patients could even accept 8 millimeters up here, but then this thing becomes too elastic, and so when you are activated, it sticks out. Okay, when you apply the force here, out, so the whole things come out because it's not rigid enough. So my
Giorgio, if we can, for example, bond an extension in the central incisor, we can do that, reach that, and
yeah, there are other options, of course. For example, you can, another thing you can do, not even bonding. I mean, if you have a very wide inside a crown that allows you to place another bracket here, this could be easier, but this is not very common. Another thing you can do is that you prepare the wire, and that's what I'm doing most of the time. You prepare the wire so that is passive, and then you make a sign here and you solder on it a stiff wire that goes like that. And this can be very stiff. Okay, this can be even stiffer than this wire here. But again, my suggestion is that you don't go more than 5-6 millimeters in order to make this more comfortable for the patient. Okay, the good thing is that we are not bringing the incisor 5 millimeters forward, but maybe 2 or 3 millimeters the most. So the change of inclination will never be so bad. So either you bend it, or you make soldering, maybe in the lab, whatever. But this is better than applying the cantilever here. And the cantilever, as you see, has this direction, the force. And this means that you will have a cantilever coming from this side. If you look at the connection between this point and this point, more or less, you see that the force is not very far from a perpendicular to the structural axis of the cantilever. So this came very natural. So a cantilever which is engaged in a tube here on the right, and then attached here to the incisor, will do most of the job. And then you will finish probably with the large space in this area. Maybe that you have those minimum of 6 millimeters to place an implant. If you need something more, you might consider to do some asymmetrical distalization here, but I don't think so. What I'm saying with this, that you are going to create the space here. Remember that also this has to be moved in this direction. Yeah.
Do I need a TED here for Anchorage, or a TPA is enough?
Well, can you tell me, I'm sorry if I reverse the question, so I ask this to you. So I want you to think. Now, let's assume that we are having a passive TPA here. Okay. And we are applying this force to the anterior teeth. What are you expecting to happen to the posterior teeth?
This force goes that direction, and the moment, because of the distance.
So the force that is applied to the posterior is this one here.
You have some distalization of the left side, George.
The CR is this. So probably you have a rotation with the CR in this area, and this goes to the distal. So the worst thing you can have, as Jose was saying, is that we have a distal displacement of this molar, which is not that bad because it's just increasing the space there.
Mm-hmm. Okay.
So it's okay. I wouldn't use a TAD. Okay. Well, I think this was an interesting case.